Hi everyone, I'm Jaya Vishwanathan, and you've found the No Brainer podcast where I discuss all things neuroscience in delightful conversations with various experts. I hope you enjoy today's episode.
Hello, everyone. It is my pleasure to welcome you to another episode of the No Brainer podcast. And today I'm absolutely delighted to be joined by my guest, Dr. Priscilla Novak, who is a very, very accomplished friend and colleague. Dr. Novak is a health economist. She's an author. She's a little bit of a Renaissance woman. Her federal career began at the Agency for Healthcare Research and Quality, and she currently manages a health services research portfolio within the Division of Behavioral and Social Research and the Population and Social Processes branch within the National Institute on Aging. Her previous career includes roles at the National Cancer Institute, Office of Personnel Management, Leading Age, the Association of American Medical Colleges, Dell, the contract with the HHS Office on Women's Health, and the Peace Corps in Bolivia. Her published research covers a whole range of topics, including racial and ethnic health disparities, local health departments, and substance use and mental health. So Dr. Novak received her PhD in health services from the University of Maryland and holds a Master's of Public Health from the George Mason University. And basically, her current portfolio includes things like economics, value-based care, and healthcare organizational behavior. So it's my absolute pleasure to have Dr. Novak here with me today. And we're so excited to bring some of our conversation that we have routinely as colleagues and friends to give you an insight into what kind of research health economists perform and how that dovetails with interest in neuroscience. And so let me start off by asking you, Priscilla, so you're a leader in the field of health health economics, as it applies to neurodegenerative diseases in an aging population. So can you tell us a little bit about your journey and what you enjoy about your work, and also some of the research that you currently work on?
Thank you, Jaya. I appreciate the opportunity to be with you on the podcast and talk about health economics and what got me interested in this topic. In terms of the journey, I grew up in rural Pennsylvania, and I was the first person in my immediate family to go to college. So I started off my college education really not very certain about what I thought of as office jobs and how did they work and what did I want to do with my one wild and wonderful life. And so I think I started off as an undergrad with a dual major in psychology and communications. And I think I might have showed up on campus on the first day looking for a psychology class, but gotten lost and stumbled into international studies introductory course. And I was really fascinated. The lecturer said, "Oh, stay, this is going to be exciting." So I stayed, and then eventually I changed my major. I majored in international economics and also did a certificate in international business. And I had to work, though, while I was going to college undergrad. And so I found a job at a local hospital, and through that job was able to get health insurance for the very first time. And to me, that was really sort of what struck my interest in health economics and health insurance, was the fact that here was this product that was sold in the United States. Some people didn't have it, and getting it, for me, was really life-changing because of the fact that once I had health insurance, I could go to the doctor and, prevent pregnancy, all the things that young people want to do. And, I think it was that interest in access to care that made me interested in health economics as a field.
So that's very interesting to me because health insurance, so I come from, as you know, a different country, and I've lived in a few different countries, and it's very interesting to me the way that countries decide to tackle something like access to care. And so the fact that it had such a profound impact on you makes complete sense, because it's the importance of public policy and politics even, right? And how that influences our health outcomes, and the reluctance maybe to seek out a healthcare provider in early age, as we know, can and does affect health outcomes sometimes. Am I right? Maybe you'd like to shed some thoughts or share some thoughts
Yeah,
about
sure.
that?
So there is a whole body of evidence about children's health insurance and
Mm,
subsequent life course impacts of having health insurance or not as a child. So basically, some of the scholars in this area include people like Michael Boudreau. And what we see if we follow people longitudinally in the United States is that not having health insurance in childhood is associated with later life poor health outcomes and poorer self-reported health. So having health insurance
mm,
is very important in terms of people's lifelong health. Um, One thing for me, I experienced a growth problem as a child and didn't have health insurance. So because of the fact our family wasn't insured, it took a long time for
mhm,
me to get appropriate care. And as a
mm.
result, as an adult, I have had health problems. So I am a case study in how that lack of
Yeah.
access to care as a child can influence subsequent physical and mental health across the life course.
And thank you for sharing that personal story as well. So, can you tell us a little bit about what are some of the questions that you research right now, or that you try to address right now, having had these early childhood and developmental influences?
So, one of the things about working at the National Institute on Aging, and I'll just say that whatever I say shouldn't be interpreted as a official position of the government or the National Institutes of Health or the National Institute on Aging. But I think one of the really great things about working at the Institute on Aging is thinking about people's health over time. And
Mm,
while people a lot of times hear aging and think of older Americans, really, biologically, we start aging from the time, some people would argue that it begins like from the time we're fetuses. Other people might argue that it's
mm,
from the time that we are sort of physiologically complete. But however you view the moment in time when aging starts, I think that there is definitely evidence that suggests that there are an accumulation of exposures over the life course, which we refer to as the exposome, right? So exposome
mhm,
refers to
mhm.
this idea that it's all of the things that you have been exposed to in your environment, whether that's physical, social, um, economic, and that these exposures accumulate across the life course and can either
Mhm.
accelerate or ameliorate the cellular aging process. And so
Right.
most of the work that I oversee as a program official is mostly focused on the provision of healthcare to older Americans. And I think when I came to NIA, I kind of went through a change in mindset, whereas before I was a program official and was doing more independent research myself, I was really focused on my research. And now, as a program official, I'm mainly focused on helping other people achieve their research
Mm,
goals. And so, of course, people need financial support to be able to do that. That's how the American academic system is set up. And so I really enjoy the opportunity to talk to people about lots of different ideas. There's,
mm.
so many different nuances in the American payment system. And that opportunity to hear from people about their specific area of expertise, and there's so many little,
Yeah.
like access to power wheelchairs, how do people perceive deprescribing, and like different
Mm.
components of racial and ethnic health disparities and how to solve those. So I love that component of service to others and like listening to their ideas and trying to understand what it is they want to do and help them navigate the system. I often tell people I'm
Right.
like I'm like a research Sherpa. I can't make the climb for them, but I can tell them where the path is and where the path will take them, and some tips about how to be ready and make the best of the journey. But that they themselves really have to take the journey. So that's kind of how I
Right.
see it. I do continue to do a little bit of writing and publishing, and I'm interested. Right now, I'm working on an article. I have a colleague who is at the Institute on Mental Health, and we're working on an article about school-based mental health services during the pandemic. And then I have another article that I'm working on about the relationship between meditation practice and serious psychological distress.
Oh, wow. So in a span of, I think, 5 minutes, you've covered so many topics that I want to dig into further with you. So let me try to maybe prioritize these a little bit. So one of the things that I was very fascinated by that you just mentioned was this idea of the exposome and how the cumulative exposures that we have in life affect us in fundamental ways. And so, but then you're approaching this from an economic principle. So, can you maybe dig a little deeper into how you approach something like the exposome from an economics perspective?
Sure, I think that's a great framing. And I think maybe we should just start with like what are the fundamentals of how economics is understood in Western cultures. And the
Right.
main sort of frame that's used in economics and capitalist societies is the concept of scarcity. And we
Mm.
use that frame of scarcity and apply it to everything, whether it's clean air or good jobs or highly trained doctors. The fundamental underlying belief is that scarcity is there and that we have to fight or struggle. There's some sort of struggle to get the good things in life, and that they're limited and not everybody can have them. I think it's key to acknowledge that as like an underlying belief in American public discourse that good things are scarce and that it's a challenge to get them, and that another part of American sort of view of life in the world is that it depends on independent personal effort, right? Like instead of a
Right.
society where we're like, oh, well, of course, everyone will need an education and they're going to need some health care, and then they're going to get old and they're going to need to retire. So we'll make sure they have basic income in old age. Some of those points that I've touched on education, healthcare, and retirement, we do to some extent have some public provision of some of those things.
Mhm.
However, there's still a lot of space, especially in the health area or the health arena, where we really leave it up to the individual consumer to figure things out. And in health
Mm.
economics, so health economics kind of uses this scarcity perspective, but thinks about health as something that is produced, and it's produced by individuals and families, and even, dare we say, societies. And one of
Mm.
the main models in health economics is formulated by an economist named Michael Grossman. And basically, his model of health production is that when we're born as infants, we have like a health stock, but that it's not fully realized. And so, if we follow
Mm.
individuals across a life course as they come into early adulthood, health stock peaks and then gradually declines. So there's this assumption of a production function. In the beginning of life, we're not capable of producing our own health without external help. And I think
Mm.
sort of a logical correlate to that is as we near the end of life, we're not capable of producing health without assistance. And I think if you look
Mm.
at care needs across the life course, this is true because both the beginning of life and if we're lucky to live long enough, right, the end of life, we tend to have care needs.
Mhm.
And so there's an economics of care as well as an economics of the health itself. I'm not sure if that answers your
Right.
question or if there's somewhere we should dig deeper.
That was fabulous. Thank you, because I'm not an economist at all, so some of these concepts are very new to me. So I really appreciate you walking me and the audience through that. That was very detailed. And so perhaps this is out of the scope of the conversation a little bit, and that's okay. But one thing that was curious to me about what you were saying is that this is maybe, and correct me if I'm wrong, but it's a way of public policy to shape or to encourage maybe good behaviors to increase quote unquote health stock and discourage bad behaviors, like say smoking tobacco, for example. And so do you see the two tying in, or am I way off pace
No,
here?
sure. Health economics uses the principles of supply and demand. And so if
Okay.
we think about a behavior like tobacco, we've economists will think about that in terms of externalities and internalities. So an externality is a cost to somebody else for a behavior that we undertake. So with tobacco
Okay.
smoking, right, typical supply and demand, when cost of a product goes up, the demand for the product goes down. Right, that's one of the
Right.
principles of economics largely. And we would apply
Mhm.
this to tobacco in the sense that government will levy taxes onto the cigarettes that will make the price go up, and then theoretically it should make
Mhm.
the demand go down. What
Mhm.
does sometimes happen in practice is that because addiction is endogenous, well, it's external to the price, right? So people are addicted
Yeah.
regardless of what the price is. They will, like, air quotes,
Yep.
need their cigarettes. Physiologically, the demand for the cigarettes is there regardless of the price. And
Mhm.
when people smoke, it causes a cost to society that they themselves do not bear, right? Because of secondhand smoke, it has negative health effects for people who are breathing it, and the people who are breathing it
Yep.
are not uh, the people who made the choice or have the addiction to smoke. So, what government often does
Mm.
in this case is with those taxes that are levied on the tobacco, which is supposed to make demand go down, they take those taxes
Mhm.
then and attempt to offset the external cost and the cost of providing care to people who are negatively impacted by the primary smoker's behavior. It also is an
Right.
attempt
Okay.
to incentivize those smokers to quit because you're trying to raise the price to a point at which consumers say, oh, this is too expensive. Another way that government tries to
Mm.
apply like patches on this problem would be when we have the Affordable Care Act, which requires that preventive services be free. Within that, many
Mhm.
health plans offer a pharmacy benefit, and then that pharmacy benefit can cover nicotine replacement products. But there are many transfers,
Mm.
and a lot of times, some of the problems that arise in healthcare when you have health insurance is that the direct cost of a negative health behavior doesn't actually get experienced by the consumer who is making that negative health choice to continue to smoke. And because they don't bear the entirety of that cost, right? The cost point where
Mm.
supply and demand meet up are not in what economists would call equilibrium.
Right. Okay. So what's next
What's next
then?
then? I
Yeah, when it's not in equilibrium for anything. I mean, tobacco is an example,
Right.
but
So I think what's next
yeah.
is that I think it illustrates the need for interdisciplinary work because of the fact
Mm.
that what health economists would be trained to do would be demonstrate how, if you raise the tax by 10%, how much should demand go down? We need people
Mm.
who can tell us that. But we also need other types of scientists, psychologists or psychiatrists, addiction specialists who can work on drug development and say, other than just nicotine replacement, is there anything else that we can give people to help them? Right? From the
Right.
psychological perspective, I think there's lots
Mhm.
of interesting questions and work around like how do you message to people in a way that causes them
Right.
to change their behavior, because just
Yeah.
increasing the cost without providing alternatives will not
Mm.
necessarily overcome addictive behavior. So there's a whole different economics of addictive behavior versus what I would call like more rational behavior, right? So physiological
Mm.
addiction requires a physiological solution. But the health economists
Right.
are there to say, like, here's what it's costing us to do nothing. Here's what we could anticipate reasonably will happen if we increase taxes.
Right, right. I mean, again, in a span of 5 minutes, you've touched on so many things I want to pull at a little bit further. Um, Let me take a step back and get back to this idea of the
Oh,
exposome.
yeah, the exposome.
B
Well, so I mean, smoking is an exposure that people might experience over the life course. But I think if we think,
Yeah.
a lot of times when people hear the word economics, they think about income, and that's pretty
Mhm.
reasonable. The exposome is the full slate of exposures. I would say it encompasses everything from the physical exposures to like social
Mhm.
interactions. So the exposome would
Mhm.
include things like colorism, racism, our education and
Mm.
the quality of that education, the food that we're able to eat, our access to healthful foods, our access to healthcare services when we need them. So I think that the exposome really covers the entirety of our experiences over the life course. And I think
Okay.
that one of the areas for innovation is figuring out how to effectively measure it.
Right. So I have two follow-up questions. So one is measuring it, but then to me, something like, say, structural determinants, like or social determinants like racism, that's a lot harder in my mind to modify or even measure. And perhaps I'm wrong, but and please let me know if I am. Than say something like lead in the water, which is a measurable toxicant that you can, if you find certain levels, you can take measures to remove lead from water, put it through purification systems. And so in my mind, there's this big question of modifiable and non-modifiable risk and resilience factors, kind of to get back to your point about how can we also add to our health stock, as you put it very eloquently, and stop things from detracting it. And so yeah, so could you talk a little bit more about like both of those? So like how do you approach deciding what's a modifiable and what's a non-modifiable, what's measurable, what's not measurable in this kind of a research
Yeah,
area?
those are all great questions. And I think for me, when I think about what is and isn't modifiable, I heard a quote one
Mhm.
time that says, all human created problems are amenable to change. Because if it's a problem that
Mm.
arises from human action or inaction, then we can modify that. It's very different when we have a problem that arises in the physical and natural world, right? Gravity is
Mm.
not a modifiable force. It's there whether we like it or not.
Right.
However, things like racism are created by humans, and therefore it
Mhm.
is amenable to change, and there are things that can be done.
Mm.
Now, you raise another question about how do you actually measure uh,
Mm.
certain exposures. And for racism, there is what is called the daily experiences of racism scale that's been psychometrically validated
Mm.
and used in numbers of studies. For systemic
Mm.
racism, a lot of times in the United States, what researchers will do is measure what we call like historic redlining, which refers to
Mm.
policies that only allowed people of color to buy houses in certain areas of towns. And so,
Mm.
while officially the policy of the United States now is right that realtors and people involved in the sale of homes are not supposed to channel people towards specific homes because of their color, we know that areas that historically were reserved for specific races and ethnicities tend to continue to be inhabited by people of that race and ethnicity. So using historic redlining in current models, or if the person was born in an area that was redlined, 50, 60, 70 years ago, using that when we're studying something now is seen by many researchers as a valid way of accounting for structural racism. But a lot of times we would call that like a proxy, or maybe some people might take what's called an instrumental variable approach. And so I think the question of how do you measure certain things, I think that's what the psychometrics is about, right? There's a whole science of testing survey items and scales to ensure that they do in fact measure what it is that we intend for them to measure. But I think when measures are based upon survey responses and answers to questions, there's the whole question of perception, right? Because what I perceive might be different from what you perceive. But if a specific group is perceiving the same thing, I mean, that's reality for that person. And so I think that there is an argument to be made for if the measure or screener has been demonstrated to be psychometrically valid, I think that we can honor the information that we get with that measure or screener. But I do think it's very important as researchers to acknowledge that we bring our own biases to the table. And so what even is worthy of study is a form of it's a reflection of the society that we live in, what it is that we are willing to support as a public as a matter of study reflects the values of our society that we live in.
Right. And that those change over time, as we all know. So that's fabulous. So we've talked about general health quite a bit. I'm wondering if you can talk a little bit specifically to neurodegenerative disorders.
Hey everyone, hope you enjoyed this episode of the No Brainer podcast and see you at the next one.